record. Okay, now that everybody's ready, let's continue on from where we stopped yesterday. Yesterday we stopped. We talked about coarctation of aorta, and also we talked about VSD, right? And before we talk about ASD, just a brief summary of VSD, how we learned VSD yesterday. The principle or the idea of how we are going to learn on how we are going to learn ASD is almost similar to VSD. So just a brief summary as to how how the content on VSD was arranged yesterday. We talked about types, right, of VSD, and we talked about how the types of VSD, they are subdivided according to the quadrants of the interventricular septum, right? And we talked about how membranous VSD is the most common one. Next would be trabecular or muscular, then outlet, and then inlet, yeah? And there was basically the main thing that was in VSD. We also talked about how VSD is the most common CVD, congenital not CVD, congenital heart disease. And by the way, VSD is common, not the most common, but then when it comes to cyanotic heart diseases, um, it is the most common one seen in peds patients, but in adult patient, when we talk about adult congenital heart diseases, ASD is the most common one. But well, roughly about when it comes to congenital heart diseases, VSD, ASD, PDA, all those things, except for the cyanotic one. Sorry, did I say cyanotic just now? The most common shunt, the one with shunting, would be VSD, whereas the cyanotic one, they are the 5 T's that we talked about, right? Okay, but anyway, putting cyanotic heart diseases aside. But anyway, that was what we covered yesterday. I also would like to again reiterate some science, specific science that we see in VSD. And why I would like to reiterate, you'll see the relevance later on. I'm just going to repeat it again, and we'll get back to it a little bit later on. And you'll see how it is still relevant when we talk about ASD and also atrioventricular septal defects later on. So in VSD, we talked about how we can hear pansystolic or hollow systolic murmur on the lower sternal border, right? With or without trills, and also S2, wide S2 split. And the smaller the defect is, the louder the murmur is, right? And so yeah, those are the main one, the sign that we see in physical examination. Of course, other things that can appear as well, signs of heart failure, signs of cardiomegaly, pulmonary edema, you see left ventricular hypertrophy, all those things. Well, those are just, it's quite logic to see that, and it's not really that specific to VSD. You can see that in so many other diseases too. So it's quite routine to see it. And if we really think about it, of course, these things would naturally come into the picture. And so yeah, that was VSD yesterday. We talked about that, and we talked about how Eisenmenger syndrome also plays into it. And we'll also talk about how Eisenmenger will play into ASD soon. So that was VSD. So let's start with ASD. ASD, atrial septal defects. Yesterday when we talked about VSD, how did we define VSD? We defined VSD as biventricular communication due to interventricular septal defect, right? Biventricular communication due to interventricular septal defects, whichever it is on the interventricular septal defect. So it is also natural to just switch that definition and apply it in ASD. So in other words, the definition of ASD is biatrial communication due to interatrial septal defects, right? Simple. Just switch the ventricles with atrium. Sure. And like I said earlier on, ASD is the most likely found in adults and in adult congenital heart defects. Why? Is because ASD is very often asymptomatic, very often asymptomatic, and it is usually found only in adulthood. And when it is found and when it is detected, it is often very serious. The manifestation is very serious to a degree that as there is a significant mortality that comes together with it. About half of the patients, when they are detected with ASD, um, they die, unfortunately, and it slowly manifests around the age of 40 to 50. So that is why the age factor comes into the picture too. And a lot of them, they die around the age of 50. So that's it. And it's also common in women, and in comparison to men, and the ratio is 3 to 1. That's like double um, the ratio that can be seen in women rather than in males. Anyway, so yesterday we talked about how there are different parts of quadrants in the interventricular septum, right? However, the I the idea or the classification or the types of ASD is not like VSD, the way it is classified. However, the idea is also almost the same. It is also in relation to the parts of the interatrial septum, but it is not divided into quadrants. It is classified according to according to the neighboring thing that is on that defect. So what are the types of ASD? I'll show you, as usual, just like yesterday, pictures. All right, can everybody see this? Yes? Okay, so if I change this picture, do you see that the picture is changed too? Or it was fixed to the first picture that you see?
It changes.
It changes too?
Yeah.
Okay, great. So I don't have to stop the screening and then again and then press another picture. Okay, no problem. All right, let's see, where should we start first? Again, I would like to also to again repeat that I would really need you to imagine things, and also to use your sense of orientation as well, because the view of where the defects are is different in different pictures. So if you can't imagine, just let me know and I'll let you know where it's being viewed from. All right, let's see, where should we start? Let's start with this one. I guess this is the simplest one. All right, this all right, so this is viewed laterally as well, just like yesterday, laterally on the right side of the heart. And it's not from an anterior view, it's not from the posterior or from the left lateral, it's from the right lateral view. All right, so here are the main um, types of ASD. According to USMLE and MRCP, there are just 2 types, but according to the ESC guideline, there are over 5 types of ASD. And when I dig some more, the the information that I got was more reflective of the ESC guideline than the USMLE and MRCP board exam resources. So I would say that one probably the resources that I got probably was not updated, or that's just the basic ones that we need to know for if you are interested to sit for those board exam. However, I think there's no harm in knowing all five types of ASD. Now, the most common type of ASD is called ostium secundum. Ostium secundum. Ostium is opening, right? Secundum or secundum ASD. You see over here, number 2. It is close to the fossa ovalis of the heart. Close to the fossa ovalis of the heart. I can't find fossa ovalis. Maybe I can Google fossa ovalis and show to everybody. Fossa ovalis. What? What here? Fossa ovalis. Fossa ovalis over here. And let's go. Wait, back to the picture. Okay. It's close again. Remember where the fossa ovalis is, and now here it is. So it's close to the fossa ovalis, and it's the most common ASD. It accounts for over 80% of all ASD cases. And the second one is ostium primum, secundum and primum. Of course, I'm arranging all of this according to the rate of occurrence, and not according to alphabet or according to importance and all that. Like of course, primum number 1 comes to primary, right? Comes first before secundum, but I'm listing out secundum first because secundum is the most common one. So the second one is primum ASD. Primum ASD. Oh, or ostium primum. Or ostium primum. Ostium primum is here over here. You see down here, the biggest one over here. This big hole. Again, I would like to emphasize on synonyms, just like VSD yesterday. Some names for primum ASD are partial AV septal defect, partial AV septal defect, partial AV canal defect. AV stands for atrioventricular. First was partial AV septal defect, second partial AV canal. Third, partial atrioventricular septal defect. Partial atrioventricular septal defect. And another one is atrioventricular septal defect with communication on atrial level. With communication on atrial level. I'd like to draw again your attention towards this name, atrioventricular septal defect with communication on atrial level. Remember yesterday when we talked about VSD, when we talk about defect on inlet, the quadrant, inlet quadrant, we talked about how some synonyms as well, yeah? We talked about how it is called AV canal. We talked about how it is called the atrioventricular septal defect type, AVSD type, right? Why? Because it is close to the AV valve. It's close to the AV valve. The same thing as your primum ASD. It is also close to your AV valve. And it's also, if you see, the names are almost the same. AV canal, AV septal defect, partial AV septal defect, partial atrioventricular septal defect. But the the defect where it is skewed towards is the thing that makes the difference. The localization can be almost the same. You can see that let's say this is the defect may be a third of the defect is is in either one of the compartments, whether the ventricle or the atrium. So that is why the name for ASD, one of the synonyms, AVSD, with communication on atrial level. It means that the defect that is on the defect, although it also crosses towards the ventricular part, but most of the defect is on the atrial side than the ventricular side. But in VSD for inlet type, it is also called partial AVSD, but it's AVSD with communication on ventricular side. It means that the defects, bigger portion of the defects is on the ventricular side and not on the atrial side. Okay, clear? Okay, now,
No, no, no,
yeah,
no. This is for what?
for
The previous,
which one?
the one that you described before, the last one.
What I described is how to differentiate primum ASD and inlet type of VSD,
Oh, in that. Okay.
because both of them cross both compartment, atrium and ventricles. Clear? Any questions? Do I have to repeat again how to differentiate both primum ASD and inlet VSD?
Repeat.
Repeat?
Yeah.
Okay. Do you have does everybody have your VSD notes from yesterday?
Yep.
Yep. Okay. Now I want you to compare your VSD and ASD right now. Now I will now first talk about ASD. Now ASD, especially specifically primum ASD. Primum ASD. The synonyms for ASD, for primum ASD, is partial AV septal defect, and it's not full AV septal defect or atrioventricular septal defect. Another name is partial AV canal. Another name is AVSD, atrioventricular septal defect, with communication on atrial level. With communication on atrial level. Now, from these names, you see the synonyms of primum ASD is in reference to a defect that is localized on both compartments, the atrium and the ventricle, right? From the name itself. It is a form of atrioventricular septal defect, if you may. It is a form of an atrioventricular septal defect. What is atrioventricular septal defect? Atrioventricular septal defect is a combination of ASD and VSD, but they are contiguous. It means that they are together, close. They cross with each other. They are just together. They are not two separate things. A lot of people think that AVSD, atrioventricular septal defects, it means that there are two separate holes, one in atrium, another in ventricle. No, that's not AVSD. That is not atrioventricular septal defect. Atrioventricular septal defect is ASD plus VSD, and they are neighbors. They are close to each other and the borders overlap. It means it's one defect that one defect that is in both compartments. In other words, just to illustrate, let's say you are standing on the border of two countries. In the middle of two countries, where are you? You don't know. Are you in Russia? Are you in Ukraine? You don't know. The same thing as this defect right here. Okay, so but they've decided to separate them regardless. And there's a way, there's a criteria how they divide it, how to know where is it actually falling or categorized under, whether it's ASD or VSD or AVSD. You can say AVSD, but then which type of AVSD? So how do you differentiate that? Is to see which side that it is skewed towards, or in other words, which side is it leaning towards. If I'm in the border between Russia and Ukraine, if um, 3/4 of my body is in Russia, that means I am in Russia. I belong. Most of my body is in Russia. So it means, in other words, most I am actually in Russia. But if 3/4 of my body is in Ukraine, that means I'm in Ukraine. That's how they differentiate um, these two types of defects. They're not mutually exclusive. So from the name itself, AVSD, with communication on atrial level, and I'm referring to ASD primum. It means that the defect, a big portion of the defect is in the atrium, and only a small portion of the defect is in the ventricle. But yesterday, if you open your VSD notes, now I'm talking about VSD, no longer on ASD. Yesterday, the fourth type of VSD that we learned yesterday, inlet, synonyms are AV canal and AVSD type. See, the name is still there. Atrioventricular canal and atrioventricular septal defect type. And it's also the same thing as well. It's close to the atrioventricular valve. The same thing as your ASD primum, right? But how to differentiate your inlet VSD and your primum ASD? By seeing which side is it skewed towards. So in other words, your inlet VSD, another name for it is atrioventricular septal defect with communication on ventricular level instead of on atrial level, like your primum ASD. So that's how you differentiate inlet VSD and primum ASD. Clear? Any questions? Okay,
Mm.
great. Okay, again, the same thing as your inlet VSD, because it is close to your atrioventricular valve. There is a tendency for that valve to be inefficient. In other words, it can regurgitate. So your atrioventricular, it is common to see atrioventricular regurgitation, or yeah, your tricuspid regurgitation here as well. So I guess, yesterday in the document that I sent everybody, where I tried to match the stenotic and regurgitant into the mild, moderate, and severe levels, right? And we could not find regurgitant heart diseases. I guess it's because regurgitant heart diseases, congenital heart diseases, they are kind of embedded into the congenital heart diseases that are already listed there, and I think they just don't see the relevance, or they find it redundant to put regurgitant congenital heart diseases into the classification. That's what I think. I don't know, but yeah, sure. Anyway, with that said, those are the two main ones that USMLE and MRCP talks about. The three, the the other three, number one, another one, the third type is, and the third and the fourth type is in reference to the vena cava, is in reference to the vena cava. You know, the vena cava enters the atrium in two different ways, the superior and the inferior vena cava, right? So simple. The two types, the two ASD is also that way too. If it's closer to the inferior vena cava, sorry, let's start with superior. If it's closer to the superior vena cava, which is here number one, it is called superior sinus venosus defect. See number one, superior sinus venosus defect. Closer to the entry of your superior vena cava. This accounts for about 5% of all the cases. Secundum was 80%, primum was 15%, superior sinus venosus defect is about 5%. The connection to the opening, it can sometimes cross partially or completely connected to the hole, the entry of the superior vena cava. So sometimes it can affect the valve as well there. So subsequently or consequently, because there is superior sinus venosus defect, there is also definitely inferior sinus venosus defect over here. Inferior sinus venosus defect, close to your the entry point of your inferior vena cava. This accounts, inferior sinus venosus defect accounts for about less than 1%, quite rare. Now, the last type, or the fifth type of atrial septal defect, is a type that is newly discovered. It is called unroofed coronary sinus. Unroofed coronary sinus. Again, let me illustrate the first four. You see over here, your primum. This is the atrioventricular valve, yeah? Do you see that it's some part of it is in your atrium and some part of it is in the ventricle? This is what I meant just now. Secundum, you see secundum, inferior vena cava, superior vena cava. And this is the fifth part, the fifth type of your ASD. Coronary, unroofed coronary sinus defect, unroofed. This accounts for less than 1%, less than 1%. Now I need to explain why is it called unroofed. I also need to explain why is it called coronary sinus. As you know, the heart itself also has its own circulation or perfusion, right? Not just artery, but also veins. As much as the artery perfuses the heart, the veins drains the heart. So it drains into, this is the veins, yeah? It drains into the coronary sinus. This big thing is called as coronary sinus. You see all the entire heart over here, all of the backflow of blood goes into your coronary sinus. And this is the big trunk. on the heart. See over here, these are all the veins, and this is where it enters the heart. This way it enters the heart. This big whole big entire thing. So, in other words, unroofed coronary sinus, it means there is an opening on the coronary sinus into the atria. And because of the opening, there is a communication between the right atrium and the left atrium. And it occurs on the borders of the coronary sinus. It means on the vein itself. There are holes on the vein. That is why the term unroofed comes into the picture. Because you see this thing occurs on top, on the superior part of the coronary sinus, and it's sort of like a roof. So unroofed coronary sinus. See fenestration in the roof of coronary sinus. Of course, your coronary sinus is not like this. You see, all it's coming out like this, and all that. This was dissected and all that. So yeah, it's not really a very good picture, but yeah, the idea is this fenestrations over here. What you have to do when you see unroofed coronary sinus is to close those defects. This is the surgery. Just close the holes, the fenestrations. Here, you see over here, this is the defect. Again, it accounts for less than 1%, so it's not really that common to see it. Clear? Any questions so far? No? All right. Now, let's talk about signs and symptoms and all that. So we know that your ASD is a left to right shunt, and yeah, so you know the drill already, left to right shunt, and also because of that your Eisenmenger syndrome, initially it is left to right, then as the right heart begins to compensate, it begins to adapt, and try to pump more blood and all that, with all the vascular changes and all that, it can shift from right to left. And see, Eisenmenger falls into the picture again, and this pulmonary hypertension and all that. So signs and symptoms, again, um, they are quite non-specific. You see the same signs and symptoms in heart failure. You see dyspnea, you see fatigue, but again, I would like to draw your attention towards whether it's symptomatic or not. Again, like I said, it occurs most often in adults, or it is not occurs. It is only detected most often in adult, or when they are adult. They are they are in adulthood. So most cases, before it starts manifesting, before it starts manifesting, it is asymptomatic, and if it's large enough, okay, probably it's symptomatic. So if it's symptomatic, you can of course hear your murmurs and all that. Now, physical examination. This is the specific thing that you'll hear in ASD. You'll hear wide, fixed S2 split. Fixed, wide S2 split. I don't know if you would like me to explain what S2 split is. I sent the video to everybody to watch and to understand what S2 split is. And before this, we already had a class explaining what S2 split is. And I hope that when you watch Dr. Najib's video, it kind of refreshes your memory as the type for S2 split. So just a quick summary. Split means that the component of the S2 is the two component, that is your A2 and P2, your um, aortic valve and your pulmonary valve, both A and P, both components of A and P is audibly heard, right? And there are different types of S2 split, your normal split, your wide split, your fixed split, and your paradoxical split. And wide split is when your and it is the splits is accentuated in during inspiration, whereas in fixed, both expiration and inspiration, that there's no accentuation and there's already obvious A2P2 split. So from here, I hope that you understand what it means by wide and fix, wide, fix, as to split. So I hope when in the future, when you come across such terms, wide, fix, as to split, they don't just simply mean English words to you because they are wide or they are fixed. It means that, you know, it's unmoved and stuff like that. I hope you don't equate what we understand in English terms and associate it and bring the same meaning into what we understand medically. And I hope that when you come across such terms, they are not just, you just don't glance through those terms, and you would actually understand the medical implications and medical significance of such terms, and you can understand what it actually means, right? Okay, so with that said, Second, second important sign is mid-systolic murmur over pulmonic area. Mid-systolic murmur over pulmonic area. So wide fixed X2 split and mid-systolic murmur over pulmonary area. ECG. In ostium secundum, in your secundum ASD, ECG is typical to see right bundle branch block with or without right axis deviation, with or without right axis deviation. But in your primum ASD, you'll see right bundle branch block with or without left axis deviation, with or
Aman,
without.
can you repeat the ECG?
In secundum, you'll see right bundle branch block RBBB with or without plus minus right axis deviation, with or without right axis deviation. But in primum ASD, you see RBBB with or without plus minus left axis deviation. And how do you see left and or right axis deviation? Is to see your first, second, third lead, right? If your R wave is higher on the third lead, it means that it is right axis deviation. If you see that it's higher on the first lead, it means that's left axis deviation. If you see it's higher on the second lead, it's no axis deviation. Or if you see that all three of the all three of them are almost equally tall in height, then there's no axis deviation, right? Okay, in chest X-ray, you see as the picture as you would expect in pulmonary edema. You'll see increase in lung roots and stuff like that. Pulmonary perfusion is increased. Well, you see that the vasculature of the heart is large, and you see the vasculature of the not heart, lungs, um, is large, and also you might also even see congestion. You see fluid in the lungs as well. They call this, according to MRCP, they call such picture that you see in pulmonary edema and increase in pulmonary perfusion and all that. They call this pulmonary plethora, plethora, plethora. In English, plethora means a combination of a lot of things, right? A plethora. So it's called pulmonary plethora. Of course, the golden standard to diagnose this is your echocardiogram. Quite straightforward. Preferably your transesophageal echocardiogram. Other points that I would like to point out. In ASD, there is a higher risk for atrial fibrillation. Higher risk, very, very high risk for atrial fibrillation. And because of this, uh, there are a few things that we need to remember. There are few cases, there are few special cases that we need to remember. In pregnancy, in pregnancy, if the patient has ASD, but there are no obvious heart defects and no lung defect and all that, the risk is fine. It's okay. But if that patient um, has Eisenmenger syndrome, has heart defects already, maybe even left ventricular hypertrophy or right ventricular hypertrophy, has arrhythmias, has history of AFib and all that, pregnancy is contraindicated until that defect is fixed, of course, until that defect is fixed. Why? Because pregnancy can change the circulation, can change the velocity of the blood and all that. And a number of patients, unfortunately, uh, when they are pregnant and they have ASD and with Eisenmenger and all that, the mortality is high. About 40 to 50%, about half of the patient die. It is also contraindicated if the patient is older. Although they don't have Eisenmenger syndrome, although there's no heart defect and all that, if there's ASD, pregnancy is contraindicated because there is risk for your pulmonary hypertension to occur, for your Eisenmenger syndrome to occur. In 1916, there was this doctor, a German doctor, who discovered something called Luthenbacher syndrome. Lutem Lutem-Barker syndrome. He discovered this specific group of patients, mostly women. They have mitral stenosis, atrial septal defects, and with or without AFib, atrial fibrillation. This combination of mitral stenosis, ASD, with and with plus minus AFib is called Luthenbach syndrome. Treatment for ASD. Oh, I'm breaking. Can everybody hear me? Last sentence. Now can. Okay. Which sentence am I supposed to repeat?
After Luthenbecker syndrome.
Everybody clear what Luthenbacher syndrome is, yeah? MS, mitral stenosis plus ASD plus minus AFib. Occurs mostly in women. The same thing, just like ASD. All right, treatment for ASD. Treatment is mostly surgical. Very rarely medical. There's not much medical treatment that we can do. It means surgical. Hmm?
You see, Luthenbecker syndrome. Mhm.
I can't hear you too.
No, your internet was bad.
Mm.
I didn't get the Lichtenberger syndrome, mitral stenosis plus ASD plus minus with
AFib, atrial fibrillation. Okay, so treatment, surgical treatment, and it is always surgical. Most of them are surgical. All right. Last but not least, I would like to talk a little bit on AVSD, atrioventricular septal defect, and I'm going to finish with this. Like I said just now, atrioventricular septal defect, it means that it's ASD plus VSD, and they are contiguous. It means they are neighbors. They are together. They are not two separate holes. Another name for AVSD is endocardial cushion defect. Endocardial cushion defect, synonym. Another synonym is AV canal. AV canal. All right. It is also if patients with trisomy 21 with Down syndrome, they are very high risk for AVSD. Very high risk for AVSD. Shunting is a mix of information that I get. Some books say that it's left to right shunt. Some books say that it's right to left. Some books say that it's mixed. So where it belongs, I'm not really sure. We'll see. Signs and symptoms. Because it is ASE plus VSD, simply put, the signs and symptoms and your physical examination and all that, you will have to expect to see both ASD and VSD signs. It means you hear your holosystolic murmur in VSD, and also it's possible to hear white fixed S2 splits or mid-systolic murmur over pulmonic area, or your holosystolic murmur on your lower left sternal border. Possible. Of course, you hear heart failure and signs of heart failure and stuff like that. That's quite logical to think about that too. Now, AVSD is an urgent problem. You see this in kids most often, in infants most often, not adults, because the mortality is very high in infants. So if you see patients with AVSD, an infant with AVSD, it is best to treat it surgically. It's best to treat it surgically. Without surgery, death is almost certain. Death is almost certain without surgery. With surgery, arrhythmias and heart block is also almost common, very common too. Of course, there are two consequences of surgery. With or without surgery, there's still consequence, but at least the patient survives, and we can solve arrhythmias, whether we want to do ablation and stuff like that in the future, or when the infant becomes an adult and stuff like that. That's another a problem for another day, but at least the patient survives. At least the patient survives. All right, finish. Any question? No, not yet. Okay, no questions yet, or not yet finished. Okay, so if no questions, in summary, uh, again, I would like to emphasize that you write down or pay attention to the synonyms, because I had to compile all the synonyms for different resources, and they are all the same. They have the same meaning, and just so that you don't get yourself confused when you study them and when you come across them, because you not only come across this topic when you have pediatric cycle, you'll also come across this topic when you're having therapy cycle in 5th year. uh so yeah, that concludes congenital heart diseases. We will start GIT next week. What the topic is about, I don't know yet, so we'll see. I'll keep you guys posted. All right, if there's no question, bye bye. Sleep well. Paka.
Thank you very much. Bye bye.